Nick Majerison here. Welcome to Top Med Talk. And on today's Top Med Talk, we're listening to a talk given at EBPOM 2018. Alison Holmes, Antibiotic, Stewardship in Perioperative Care. Have a listen.
Top Med Talk.
Many thanks, Angela. Our final speaker for this morning, it's a great pleasure to welcome Professor Alison Holmes. Alison is a Professor of Infectious Diseases based at Imperial College London. She's doing some really fantastic work around antimicrobial stewardship. She has many accolades, including being an NIHR senior investigator, which means that she's really, really good at that. So she's here to talk to us about antimicrobial stewardship in perioperative care. Thank you, Alison.
Thanks, Ramani. Good morning, everybody. It's a real pleasure to be here. Thank you so much. I just want to set out why this is so important, and I want to pick up on what Saul Aronson was saying yesterday, because I actually think that perioperative care is about addressing population health, and I think that's something that we really should take on board. So just a little bit of background about why we're talking about this and why it's so important. The global burden of AMR is just enormous. It's getting bigger. We all need to be involved. The significant economic burden, action has an impact, and the impact, of course, is not just economic, but on direct patient outcomes. So it's really important that we do something about this, and we can have an impact. So this was the data from the Jim O'Neill report about, there'll be 10 million deaths a year by 2050 if we don't do much about this. But I think the other important thing that I want to pick up and I want to keep referring back to is that low and middle income countries, of course, are paying the price. They are paying the price of this, and we need to continue to think about that, and I'll be referring to that a bit. And it's particularly nuanced because, of course, it's not just all about excess, it's about access as well. There are more problems with people globally not being able to access effective infection treatment than the issue around AMR. But if we're wanting to have sustainable access to effective antimicrobials to treat infection, we really need to do something about how we optimize our management without compromising access. So very important that. And of course, this led to the most incredible international leadership around this. The idea that antimicrobial stewardship and antimicrobial resistance would be discussed at the UN General Assembly is really quite amazing, with 193 countries signing up to do something about this on a declaration. Quite extraordinary. But the other thing that was quite extraordinary was that this became a cross-sectoral issue. It wasn't just about healthcare, it was about food production and the environment. And here you can see this is Margaret Chan, the ex-Director General of WHO, and Amina Mohammed, the Deputy Director General of the United Nations, saying to develop action and deliver on this, they'd have an interagency coordinating body to actually work cross-sectorally and deliver on this. And our Sally Davies, our Chief Medical Officer, is on that group. So pretty powerful women overseeing this and doing a very, very tricky, complex task. So one of the biggest issues and why the UN is right behind this is because the issue of the Sustainable Development Goals, so the SDGs. So these are what the globe is looking for to improve health, to improve poverty. And it's believed that unless we address antimicrobial stewardship, many of these Sustainable Development Goals will actually not be achieved. So it's absolutely critical. This is a big aspect of population health, and perioperative medicine is a key part of this. So whilst the UN were doing this, the other leaders around the world, the G20, were taking this on board. So in 2017, they pledged to do something about it. And at the meeting now, of course, the leadership is Argentina. And at the G20 meeting in October, antimicrobial stewardship, antimicrobial resistance will also be discussed. So what is it? It's not just about making things cheaper, although, of course, that's attractive in some areas, particularly the NHS. Actually, it's about optimizing treatment, optimizing choices, and optimizing treatments and minimizing unnecessary exposure. So most of us are working in hospitals, and this is the problem in hospitals and what we're doing wrong. 33% duration too long, and in fact that bar would be much higher now as the evidence base for durations, and the durations are coming down. Treating things that aren't infectious, treating of colonization, and also lots of redundant antibiotics. And of course we need to think of unnecessary line use, toxicity, and C. diff as well. So whilst we're talking about hospitals, what are the specialties that are using these? So this is the spread of specialties within Europe. Most of the surgical ones are at the top, and they kind of drift down as we get to the bottom. But coming back to the NHS and thinking about how we use antibiotics within our hospitals, within the NHS. So around 34% of all our inpatients are on antibiotics. And the concerning thing is, and you think, my God, and 20% of those are for infections that we give them in hospital. I mean, good. That's one way of sorting things out. Really extraordinary. And a lot of those hospital-acquired infections are, of course, surgical-related. And then 13% surgical prophylaxis, and over 30% of those are actually unnecessary, and we've done pretty badly. And then the latest data, this is just from last year, it's interesting to see some little shifts, more for community infection, which might be about responding to sepsis. Unfortunately, the hospital-acquired infection, just as high. And although the amount being used for surgical prophylaxis has gone down, it's still being used for far too long. Anyway, yesterday and today we've touched upon about how to change behaviour and drive quality improvement within healthcare. And there's so much evidence that, we need to move beyond thinking that things are a quick technical fix and needs real technical experts to actually thinking about how we can involve people, make it a social issue that can be addressed by teams, communities, and not through simple technical fixes. And this has been shown over and over again, and again was discussed yesterday. So success depends on building teams and communities. So that's our St. Mary's team that were in that glorious documentary, Fly on the Wall at St. Mary's, and those are their lovely faces. Multidisciplinary, multiprofessional, fantastic. However, what on earth are we doing about antimicrobial stewardship? So, multi-professional, oh my goodness. We've only started recently in the last couple of years involving nurses and pharmacists. Huge amounts that can be learned, particularly in roles in HIV and TB. Masses of work, huge, complex work, and nurses and pharmacists. We've run programs for pharmacists. The development of roles in Australia and the US are so enormous, and yet in the UK it's only taken us the last couple of years to drive this forwards. And this is colleague Esmita Sharani, who's at the moment working in Kerala with an amazing group of pharmacists, Amrita Hospital, looking at antimicrobial stewardship. Nurses, largest workforce in the world. We need to be using them more. Absolutely extraordinary, and we need to be doing much more about this, and lots is happening in this space, which I'm pleased to report, and real movement to engage nursing leadership in antimicrobial stewardship. Fantastic, lots happening there. However, those are the multi-professional angles of this. Fantastic, let's work with our nursing colleagues and let's work with our pharmacy colleagues. More has been done about that than actually working with your other clinical specialties. So just quite extraordinary. Cross-specialty clinical engagement has been pretty appalling. So this is data looking at 60,000 abstracts from state-of-the-art international conferences. So, and this is the amount of times that anything about antimicrobial use or resistance was discussed. Now, of course, I'm an infectious diseases specialist and think that, infectious diseases people are the brainiest, non-single organ type of doctors, and they need to know not only all about the patient and be so clinically up there, they also need to know all about the organ, etc. And, of course, they're the ones using the most antimicrobials at the top there. But what really, really I find terribly anxiety-provoking is that, emergency medicine, they're not too interested in it. Hematology and renal medicine, dear God, renal medicine, not talking about it. When you think that, hematology, bone marrow transplant programs in Italy closed down because of the problems of antimicrobial resistance, and yet hematology not talking about it. Transplantation, renal transplantation would be impossible, and yet we're not talking about it. So I think that's pretty interesting. It shows how terrible we are. And this is a big questionnaire around the world on asking surgical teams. I think it's a little bit pathetic that nurses don't feature there, anaesthetists don't get mentioned there. I appreciate they might be under intensivists, but even so, I think this is really not too great. I think we could do better. And we haven't even got to patients, by the way. I'm not covering that there, but that's something we're really interested in and have done a lot of work in. And interestingly, that papers are being rejected in the UK because they didn't think it was was relevant to talk about patient engagement and involvement within secondary care about antibiotic choices. Extraordinary. Anyway, surgical specialties responsible for a huge amount, and there's been a large paper in the Lancet about what would happen in the modelling around if we even lost a little bit of sensitivity, the impact on surgery and on cancer. Quite extraordinary, and most around the perioperative period, of course. So I just want a little bit about local NHS experience. Surgery, there are patients using it for far longer. We are seeing also poorer compliance. We're seeing horrible outbreaks of carbapenem-resistant enterobacteriaceae costing millions. And the other thing is, we need to move away from thinking that it's all about surgical site infection. It's not. There are many other infections. And the other thing we need to think about is the complete overdiagnosis of hospital-acquired pneumonia and that antibiotics have a diuretic function. So that overdiagnosing of pneumonia is something that perioperative experts really need to get involved in. And what's become clearer and clearer is that it's not just the choices and it's not just the diagnosis. It's about how all of that decision-making is being made, and can we understand it a little bit more? This has led to some really nice qualitative work, and it was a real pleasure to work with Liam and now Ramani, looking and trying to dissect out a little bit more about where is the decision-making. So this paper is, I'm just putting up a few points here, but it was a massive kind of qualitative study, a lot of ethnography in this, and of course it came up yesterday with somebody talking about pain management, about being peripheral to the role of surgeons. It was extremely disjointed, and there was a lack of clarity around decision-making, which absolutely undermined effective use of antibiotics and the expectation that it could be given to other professionals. So there is a real role for thinking about perioperative medical specialists who could take on this role of looking at how best to use antimicrobials. So much opportunity there. There's also a very, very kind of complex causal mapping, which also shows the role where prevention and antibiotic usage can come together and where perioperative medicine could have a real impact. This has also led to a much larger scoping piece of work internationally about where are the gaps in decision-making. And we picked up again about this issue about lack of clarity. There's also an issue about who's taking responsibility for prevention. And also, we absolutely need to know a little bit more about the culture and team dynamics. And that is context-specific. How we make diagnoses, really important. And the other thing is, as I mentioned before, some of this is a problem with lack of access to antibiotics. And we may think this is a developing world problem, but can I just remind you, within the NHS, this last year, we've had the most enormous problems with the most basic antimicrobials and shortages. And I'm sure within your own trust, you've had to radically rethink how you use antibiotics, and from tazocin to gentamicin shortages. So just coming back to the LMIC context, this is completely going to undermine healthcare. I cannot stress enough that particularly gram-negative resistance will undermine the delivery of healthcare. It will absolutely not only devastate clinical outcomes now, it will completely interrupt our capacity to innovate and take things forwards. An enormous problem. A big paper in 2018 in The Lancet by Bicard et al. Showed the massive problem that this is and how infection is one of the largest components of these poor outcomes in post-surgery in this large African study. Okay. I just want to pick up on this issue about surgical site infection and a huge attention on what can be done to prevent infection. We need now to do a lot more about what we can do to optimize antimicrobial prescribing, which will have an impact not just on that patient, but on your next patient and also on society at large. And I think it's time that we move away from just looking at SSIs and do a lot more. And I'm delighted that we've got funding from the ESRC, and this makes a real difference at Imperial, where people aren't known for doing social sciences. And this is a nice collaborative piece of work with South Africa, India and Kerala, and also with our expert anaesthetists, who there are very few of in Rwanda, also working with us. And very pleased to be working also with Ramani on this, and I hope in a year or two's time she or others will be able to come and maybe talk about this at this meeting again. Thank you very much indeed for having me.
And don't forget, you can meet the Top Med Talk team. All you need to do is turn up at one of our events. Check out ebpom.org for more details. ebpom.org. Our next big event is between the 28th and the 30th of September in Chicago. That's EBPOM USA, the Chicago Masters Course, Perioperative Care Practicum. Between the 28th and the 30th of September, ebpom.org for more details. That's ebpom.org.